Good afternoon. First of all, let me congratulate BIHA for organizing such a wonderful meeting. It's already a success. So, when you are discussing lens-induced glaucoma, these are the different conditions which cause the glaucoma. Among these, phacolytic and phacomorphic glaucomas are the most common, and I'll be discussing these in my presentation. So the definitive treatment for lens-induced glaucoma is cataract surgery, but you have to manage the inflammation and glaucoma as the patient is waiting for cataract surgery. A lot of challenges in cataract surgery in these cases. Many of these cases you'll have a shallow anterior chamber. Endothelium is frequently poor in these cases for many reasons, including the inflammation that is going on there. There will be challenges in management of anterior and posterior capsule. Frequently, the zonules are weak in these cases. And many of these cases, though it'll be white, you'll see a camouflaged brown or black cataract underneath. So, this is a case of phacolytic glaucoma. You can see all the leaked lens mat material in the anterior chamber. Like once you wash it off, you will see the dense brown nucleus underneath. So this is another problem. See, this is another case, phacolytic glaucoma. So, I mean, you have to stain the anterior capsule with trypan blue in all these cases. You will, I'm not able to fast forward it. I mean, so this is, once you wash off the trypan blue, you'll see it's nearly a 90-degree zonular dialysis. So, there might not be this much of zonular dialysis in all cases, but you can expect weak zonules in almost all the cases of lens-induced glaucoma. Another issue here is the anterior capsule running off to the periphery. Can I fast forward it? कुछ आगे करना है. वीडियो आगे करना है. कुछ नहीं आ रहा इधर. छोड़ दो. Okay, so it runs off to the periphery, and the way to manage it and prevent it is by planning two-stage rexes. Initially small rexes, decompress the back, and then enlarge the rexes. The only issue is it'll take more time. So this is where you do. Ma'am has already shown this. So initially small rexes, decompress. I'll just go for the other one. So the basic idea is to have a small rexus in the beginning. Make sure that it stays at the center. All the movements should be towards the center to make sure that it doesn't run off to the periphery. So that is what is being done here. You can see the pull going on to the center, but you'll have a world champion appearing in no time. So if this happens, this is a well open area now. If you do phaco through that, it's definite that it's going to fall down. But if you make a rexus on both sides, you can cut it either with vanas or micro scissors, and make the rexus with utrata forceps or micro rexus forceps. So this is how you have to make space enough for safe phacoemulsification. So I just wanted to show the orientation of intraocular, but it's going to, I'm not able to fast forward it. Let's go to the next one. So here again, the same thing is done. There is an extension to the periphery. The basic idea is like if the rexus extension is in one direction, the haptics actually should be oriented 90 degrees to it. So I'm not going to, if you permit me, I'll just show this here. So once the phaco is done, aspiration done, so the orientation of the haptics should be at 90 degrees to where the rexus has extended. So that is the take home from this. So ma'am said mean, for me, my preferred technique to prevent this is to decompress the bag using a 2060 needle. So the trick here is you should not just go in with the 2060 needle, poke it and then aspirate. The idea is to have a negative pressure at the tip of the 2060 needle when the needle is in the anterior chamber. So as soon as you enter, you are aspirating. Otherwise, you touch it, many of the cases it just runs out to the periphery. So this is a trick. You aspirate and go in. I don't get a 30 needle in my OT, so I use a 2060 needle. It works quite well. So there again, in the first video, you can see a small rexus being done and that being enlarged. The other one, I could do a large enough rexus to do a safe phacoemulsification there itself. So another technique is the technique that is popularized by our dear Mohan Rajan sir. I'm just showing it to you to show that it can be done. But I really don't prefer to do it. You just go in with full power phaco and cut the capsule and aspirate. In my hands, a 26G needle works with much more control. So that is my preferred technique, just to show that there is another technique that is possible. So this is this is another problem that you can face. Phacolytic glaucoma case. You start the capsular rexus. The anterior capsule is very loose. You can see the whole bag is loose. So once you open the anterior capsule, the liquefied lens matter comes out, and what you see underneath is a small but a dense nucleus. So you do phacoemulsification, try to keep it in the bag and do phacoemulsification. The posterior capsule is very loose. It has a tendency to come to the phacotip. So it is a bit dangerous. So my preferred technique in these cases is to put an IOL in the bag. So that gives you an IOL scaffold there. So when you do phacoemulsification, you try to chop, you get a funny feeling. This nucleus keeps on slipping on top of it. But you eat up a bit in the periphery, then you get a hold, and then you can do phaco. And you feel that it's more dangerous, it's going near the endothelium and all. But you use viscoat. But here actually you have a chance to go much away from the endothelium, because you know that it is not going to catch the PC. So that way also it is much away from the endothelium. So to conclude, the definitive treatment for lens-induced glaucoma is cataract. But as the patient is being prepared for cataract, control the inflammation using frequent topical steroids and all possible anti-glaucoma medications. If it is phacomorphic glaucoma, and if you expect that you might have to put a primary iris color lens, I prefer to do a AIOCMTC1. TRAB is not really necessary in these cases. Manual surgery, yes, it works. Use trypan blue, use viscot or any other alternative. CCC, careful CCC, as I explained, slow motion phaco. Do you need a higher end phacoemulsification to manage these cases? Not really. Like whatever phacoemulsion that works for your other cases works really well in these cases. Postoperatively, use frequent topical steroids and anti-glaucoma medications to be continued till you really are sure that it is no longer required. See, these are two videos. The first one that I showed initially, that's liquefied lens matter in the anterior chamber. So what is the other one? Is it a white cataract there? So is it really white cataract? You can see it actually is. See, I'm actually touching the PC there. It's actually liquefied lens material in the vitreous. Many times I've actually done a posterior capsular rexus to drain it, but here I didn't do it, and it gets absorbed on its own. Just wanted to show something a bit different. So that is it. And again, this is another reason for my visit here to invite. And Habans sir will be taking over as president there. That's one more reason for you all to visit there. And it's a really nice place to be. And contact me, Gopal, Thomas Cherian also has come. Please come, don't miss it. Thank you.